Chào mừng quý khán giả đã đến với series podcast Kiểm soát cao huyết áp, bao gồm các buổi phỏng vấn 30 đến 45 phút của bác sĩ Madhukar Shahi về các chuyên đề liên quan đến cao huyết áp, như chẩn đoán trong bối cảnh thăm khám tổng quan, cao huyết áp trong thai kỳ, cao huyết áp ở nhi, ở người cao tuổi, và nhiều chuyên đề hấp dẫn khác. Tập đầu tiên của podcast series cung cấp kinh nghiệm và kiến thức lâm sàng về việc dùng thuốc lợi tiểu, được chủ trì bởi Anirban Lahiri, CEO của Medanta Việt Nam, là một nền tảng chuyên cung cấp công cụ kỹ thuật số cho cộng đồng y khoa tại Việt Nam. Sứ mệnh của Medanta Việt Nam là mang lại một nền tảng giúp kết nối các bác sĩ Việt và chuyên gia quốc tế đầu ngành qua các webinars, series bài giảng, podcast. Để theo dõi thêm các nội dung tương tự, vui lòng tham gia nhóm kết nối bác sĩ Medanta Việt Nam. Link để ở phần giới thiệu.
Good morning to all our listeners. This is Mediceta's podcast series. Today we're featuring Dr. Madhukar Shahi, who is an accomplished cardiologist at Narayana Health and Fortis Health with more than 20 years of experience in clinical and interventional cardiology, over 10,000 interventional procedures, including coronary and peripheral interventions, valvuloplasties, and device implantations. Today's topic is particularly important because hypertension is a worldwide problem and is actually increasing in terms of prevalence across various nations and regions of the world. Diuretics have long been used as useful hypertensive agents, and there is compelling evidence for their efficacy in patients with heart failure, elderly patients, patients with isolated systolic hypertension, and patients of African American origin. Thiazide diuretics are the most commonly prescribed diuretics for hypertension, but other classes of diuretics may be useful in alternative circumstances. Although diuretics are no longer considered the preferred agent for treatment of hypertension in adults and children, they remain acceptable first-line options. Source Blawi 2016, Pediatrics, Nephrology, Shah et al. 2004, Postgraduate Medical Journal. With that being said, we're going to jump right into the questions with Dr. Shahi. So let me start with the first question. Dr. Shahi, what is your strategy to choose diuretics for each stage of hypertension? How would you use diuretics for a patient with hypertensive urgencies along with heart failure and hyponatremia?
Good morning to all the listeners, and it's a pleasure to be on this platform. It's amazing that we can use this technology to reach out to more and more people. And I'm really glad to be speaking about this important topic because hypertension is very common in Southeast Asia, South Asia, and East Asia. We as a group of people, earlier I did mention about blacks, but as a group of people, we are extremely diuretic sensitive, both in East Asia, in Southeast Asia, and South Asia. And therefore, this topic assumes more importance. The question is, which Anirban asked me, is what is the kind of strategy or what is the kind of medication or diuretic that one would use in hypertensive urgencies, especially if there is heart failure and hyponatremia. Now, these are three different questions because in hypertensive urgencies is a little different situation, but you also have heart failure and you also have low sodium. We know that any diuretic, when we use any diuretic, absolutely will decrease serum sodium even further, and that actually puts the patient at risk of hyponatremic symptoms. Ideally, when you use a diuretic in a hypertensive urgency, you would try to use a loop diuretic because you want the effect very fast, and you can achieve higher levels of loop diuretic in the renal tubule to be able to act. None of the thiazide or thiazide diuretics will actually be effective. Also, you need the medication to be intravenous because this is a hypertensive emergency, and you cannot wait for an oral medication to be taken and then the effect to start. So you use bumetanide or you use furosemide. These are the two most commonly used medications in hypertensive urgencies as an initial treatment. One must realize that hypertensive urgencies often are volume contracted already, and they are high renin states, and the GFR or the glomerular filtration is already low, And therefore, it becomes a challenge using diuretics or continued use of diuretics in this patient because it impairs renal function even further. So you're going to be depending on the other class of antihypertensive medications, which can be given intravenously, IV nitroprusside, IV nitroglycerin, IV labetalol, IV esmolol. But at the same time, when there is pulmonary edema, patient is breathless, and the patient is volume bloated because of renal dysfunction, and the patient is kind of edematous, you would like to use an intravenous diuretic, like a loop diuretic. The second part is that if the patient is in heart failure, obviously in this situation, you have to use an intravenous diuretic, which is again a loop diuretic, and higher doses, 100 milligrams twice a day in that dose, or sometimes an infusion of furosemide, which gives you a much higher level in the renal tubule so that at least the diuretic can act. Rarely you may need to actually do an ultrafiltration because none of the diuretics really act. You may have to take out the fluid using a dialyzer. The last part of the question was, what if the patient has hyponatremia? Now, among the diuretics, the loop diuretics, although they are most potent in putting out urine, they don't tend to cause so much of hyponatremia as compared to long-term use of the thiazide or the thiazide-like diuretics. That is simply because the loop diuretics have a much shorter duration of action. And once the action is over, the body can rebalance itself. So when you give Lasix and it lasts you about 6 hours, then the remaining 18 hours, the body again retains homeostasis and gets back to some kind of a volume status and its sodium balance. And therefore, it is safer to use loop diuretics when the patient has hyponatremia as compared to using continued use of thiazide diuretics. However, any hyponatremia can result in symptoms, and Lasix or loop diuretics can increase hyponatremia, and that's a concern. So therefore, the best treatment in that kind of a situation would be to restrict overall fluids so that you have sodium coming up rather than trying to get rid of more fluid. And then it would be interesting to see whether we can use some newer agents, which are not actually diuretics, but they have a strong, potent diuretic action, which is the tolvaptan kind of groups, which is an arginine vasopressin 2 receptor blocker. It is often used to treat hyponatremia in patients who have heart failure, where the sodium is not coming up. And recently, the gliflozins, or these are medications primarily used in diabetes. Increasingly, they have been approved for use in heart failure, and they are medications which can increase the excretion of what is called free water. So you want water to come out of the body, but you don't want sodium to get out. Most diuretics will actually remove sodium and indirectly remove water. So that is why a diuretic is a natriuretic, or it's a saluretic, that means gets salt out. But these two medications, they actually get water out. So it's like free water. The gliflozins actually get water out by putting in more glucose in the, filtering more glucose into the tubule, which actually then draws out water secondarily. So that is an interesting application, which I think may find use increasingly in patients who have hyponatremia.
Thank you, Dr. Shahi. That was a very comprehensive answer to a pretty complex question. Perhaps we should have split that question into its subcomponents, but thank you for that answer. I guess my next question is, in your experience, how long should diuretics be used to maximize efficacy and minimize side effects?
When we use diuretics as an antihypertensive, the assumption is that this is going to be a treatment which is going to be lifelong. So therefore, when you talk about how to maximize efficacy and minimize side effects and how long, the question of length really depends on whether you're going to use a diuretic as a short-term add-on to an already existing treatment. So for example, if I find that the patient has been on A and B medications for blood pressure, and the blood pressure is not well controlled because of reasons which are transient, for example, indiscretion in diet or because the weather is colder, then I would use a diuretic for a shorter period of time till I get the values to the targets that I want. But apart from that, if I'm using a diuretic as an overall strategy to control hypertension in these patients, then obviously these patients have to be on the diuretic for the long term. How do you maximize the efficacy of the diuretic? Now, most diuretics, have two problems, or let's say two effects. One effect is that there is a certain amount of volume contraction which occurs in the body because of diuresis or loss of water, loss of fluid from the body. Now, this actually sets up, increases the activation of the renin-angiotensin system, and therefore it tends to which again tries to sort of get fluid, retained into the body. So you're trying to give a diuretic, you try to concentrate, you get rid of fluid, and then the body balances itself in trying to sort of activate the renin-angiotensin system in response. Therefore, if you want to increase the efficacy of diuretic, you may be better off adding an ACE inhibitor or an ARB, which inhibits the renin-angiotensin system, so that you don't get the pushback from the RAS system in response to the diuretic. So you can increase the efficacy by combining two of these medications. So they, in fact, will act synergistically. The other advantage of combining something like this is that it tends to cause less potassium loss. The ACE inhibitors or ARBs tend to retain potassium. The diuretics tend to decrease potassium. And so therefore you might have a balance where you get less potassium loss and less hypokalemia when you combine these two medications. So those are some of the ways in which you can increase the efficacy of the diuretic. How do you minimize side effects? Like I said, combining medication is one approach. The second thing is that to start with a lower dose before you try to increase the dose. One must remember that diuretics, really increasing the dose too much doesn't really help. You start with the lowest possible dose and go to the average dose. It's very rarely that you require it to be used in much higher doses. So that is one way to increase and keep fluid intake, to increase potassium intake. For example, coconut water, this tries and helps you increase the amount of potassium that you're taking, so you don't have hypokalemia, because that is one of the most common side effects, hyponatremia, hypokalemia of diuretics. So that's about it. I mean, you must also understand that diuretics really have bimodal effect. One is, of course, the volume contraction, but it also causes a long-term vasorelaxation, which is what the primary mechanism of action is. When you look at starting a diuretic, it almost takes about a month or so for the full effectiveness. So don't be in a hurry to increase the dose very rapidly. In that case, the chances of side effects are much higher. Be very careful in people who already have mild renal dysfunction. In these patients, the diuretic may not be as effective. Also be careful in people who are elderly, because they are more sensitive to volume loss. They can have postural hypertension. So in these patients, you may want to check for postural drop in blood pressure at every visit. You may also want to use medications which are shorter acting. Now, most of the societies have indicated, especially the US societies, that longer acting medications like chlorthalidone or indapamide, they are more potent and they should be preferred diuretics. Increasing, there is data to suggest that the use of chlorthalidone has significant side effects in terms of hypokalemia as compared to hydrochlorothiazide. So the data on both these things is a little sketchy. The recommendations today for most societies is that you use chlorthalidone because it acts for a longer duration of time. It has been shown to reduce cardiovascular events, but at the same time, our concern is about the side effects, and especially in view of the fact that most societies are switching over to use of combination at the outset. Use of an ACE inhibitor or ARB with a diuretic may in fact be a better choice than using a drug like chlorthalidone on its own. When we look at the diuretics, you might want to also think that what is the kind of diuretic I would like to use, and which may be possibly the best diuretic to use in essential hypertension. Some data is there to suggest that indapamide may be the one which has a long, it's a long-standing effect, and with the least amount of side effects in terms of it is neutral towards glucose, it does not change lipid profile, it has hypokalemia is about the same with any of these diuretics, and uric acid, I mean, it does raise uric acid like any other diuretic, but it tends to sort of have as good effect as clothianidone on most of the cardiovascular events, with less side effects in terms of glucose intolerance and change in lipids. So I would tend to think that, among the diuretics, one is better off using indapamide as compared to the others.
Thank you, Dr. Shahi, for the answer. You mentioned the sensitivity or risks around age when it comes to gauging the duration and of diuretic use for treating hypertension. So may I just delve a little bit deeper into that and ask you, what are the considerations when choosing diuretics groups according to age and ethnicity? Could you touch upon that briefly for our audience?
Right. So we know that diuretics would be the drug of choice in individuals with what is called low renin hypertension, or indirectly volume expanded states. Now, when we look at where most of these societies have recommended use of diuretics, they've clearly recommended diuretics for people who are older. Now, that doesn't mean when we say older, we have to stop at a particular age, because we know that the elderly, for example, somebody who's 80 plus is going to react differently to a diuretic as compared to somebody who's more than 65, let's say. So we have to keep that into consideration when we say the elderly or the older adults would do better with a diuretic. Then we also know that people who have more volume retention, for example, people with obesity, some amount of obstructive sleep apnea, these patients do better. Patients who have edema, for example, blood pressure with some swelling in the feet, they do better with diuretics. We know that patients who are diabetic, they tend to sort of have, a greater response with diuretics. Of course, racially, we find that blacks, most societies, American societies especially, recommend that. But looking at our population itself, somehow, in our population, in our area, when you have obesity, then they are more sensitive to diuretics. Also, we find that in Asians, we tend to have more what is called nighttime hypertension and early morning hypertension. These patients actually respond to diuretics in a much better fashion. So diuretics are useful as a group in our part of the world. As far as the elderly are concerned, we need to understand that as you grow older, the arteries stiffen up, and so isolated systolic hypertension is more common as you grow older. In those patients, the mechanism is not volume expansion, or even it's not because of increased peripheral vascular resistance, because of increased RAS activation, because RAS is blunted as you grow older. So here you're trying to treat the vessels directly in trying to sort of relax the vessels, the large vessels. And therefore, the choice of medication is one which relaxes these vessels. So it causes some vasodilatation. And diuretics do that. And of course, calcium channel blockers, which are direct arterial dilators, they do that. So therefore, one tends to prefer calcium channel blockers or diuretics in this kind of patients.
Thank you very much. My next question is, can diuretics be used to treat postpartum preeclampsia? If yes, what type of and which situation should they be used?
Right. See, diuretics as a class itself, is especially the thiazide diuretics, and the potassium-sparing diuretics, they are contraindicated in pregnancy. And therefore, and so when we look at pregnancy and preeclampsia, then we have to talk about whether we are talking before delivery or we are talking postpartum. So let's say antepartum, intrapartum, and we're talking about postpartum. I will put the intrapartum, that means during labor and delivery, and postpartum together, and the antepartum separately. Now, antepartum, you don't want to use a diuretic. Usually in eclampsia, preeclampsia, or hypertension, or what is called gestational hypertension, there is a certain amount of volume contraction. Of course, pregnancy itself leads to some volume expansion during the second trimester. But generally, once the patient has eclampsia or preeclampsia or gestational hypertension, there is a certain amount of volume contraction, and you don't want to exacerbate volume contraction by giving a diuretic, because these patients have already an affected glomerular filtration rate. The GFR is already a little low, and you don't want to dehydrate the patient. Also, use of diuretics can cause oligohydramnios, which can affect the child and is known to cause fetal malformation. So therefore, diuretics during pregnancy, no. Sometimes if the patient has heart failure and heart disease, you can use a diuretic, and most of the time it's a loop diuretic. But that again is not a long-term use. It's a short-term use to get rid of edema and volume. And then in those cases, it is safer to use a loop diuretic. But thiazide diuretics and potassium-sparing diuretics, no. The question directly was, what about postpartum preeclampsia? So obviously, we're talking about blood pressure during and after delivery. Now, gestational hypertension or preeclampsia lasts about 6 to 12 weeks. By definition, 6 weeks. What happens with labor and delivery is that there are a lot of volume shifts, and actually the mother's blood volume grows up tremendously, and that can exacerbate preeclampsia or gestational hypertension immediately during delivery and post-delivery. There comes the role of giving diuretics, and again, here we tend to use any diuretic, but since the expansion of blood volume has occurred very rapidly, we would like to use a loop diuretic. Some trials are there to show that a small dose of furosemide given during intrapartum and postpartum for a short period of time, for a week, 5 days, actually helps control blood pressure and prevents the reappearance of preeclampsia postpartum. So that may be an interesting way to manage these patients.
That is interesting. Thank you. The next question is for diuretics associated with hypokalemia, example, thiazides. Should we proactively retest for blood potassium when patient does not presented with dyskalemic symptoms? If yes, what is the suitable time over which this?
There is absolutely right. There is always a concern of hypokalemia when you use any kind of a diuretic. And like I said earlier, thiazide and thiazide-like diuretics are more prone to cause hypokalemia. The longer acting ones more so. I mean, it's been clearly shown that chlorthalidone is worse in terms of hypokalemia as compared to hydrochlorothiazide. So therefore, whenever we intend to use a diuretic as a strategy to manage blood pressure, it is very important to check a baseline potassium level in every patient who comes to us with blood pressure. There are two reasons for that. One, of course, you establish a level of potassium which is safe for you to start using a diuretic. The second is that spontaneous hypokalemia is a marker of increased aldosterone, and therefore you might pick up a secondary cause of hypertension in these patients. So therefore, it's absolutely essential that one does a baseline potassium level before one starts a diuretic. Once a diuretic has been started, for most of the thiazide diuretics, I'm not saying about the thiazide type diuretics, so like hydrochlorothiazide, the chances of potassium hypokalemia is low. However, we must understand that some of this data usually comes from Western societies or what is called the temperate zones, and we live in a tropical area, and therefore it may be different in our country. In our country, in India at least, we see the chances of hypokalemia significantly, and therefore we tend to measure it more often. So you get a baseline potassium done. Now, after you've started the patient on a diuretic, it has to be, assuming that the diuretic effect has taken about 3 to 4 weeks, you would want to check serum potassium level again at about 3 to 4 weeks to see where you are. And after that, you may want to check it every 6 months, or you may want to check it every time you increase the dose. So every time you increase the dose, you wait for another 3 weeks and recheck it. And you would also want to increase it if there is, or check it if there is any intercurrent illness. For example, a patient has fever, vomiting, diarrhea, is a midwritten illness, in that situation where the patient is not eating enough. So you want to check the potassium level. So intercurrent illness, you want to check potassium. Standard checking 6 months. Increase in dose 3 weeks. Start off baseline. So this is how you want to check this. Then you would like to be a little more careful in patients who have some diabetes or chronic renal dysfunction. In these patients, hyperkalemia is quite common, and therefore, especially in diabetics, they can have a condition called hyporeninemic hypoaldosteronism. And in these patients, you will tend to have hyperkalemia quite fast. And therefore, you want in diabetics, I would recommend that you need to check potassium level every 3 months.
Thank you very much for that comprehensive answer. The next question is, for lupus patients with proteinuria, can finerenone be used?
Now, finerenone is a very novel medication. We have been sort of using what is called aldosterone receptor antagonist, or what is called an MR antagonist or MR blockers for some time. The most popular one is spironolactone. And more recently, because of the side effect of increased potassium, hyperkalemia, and intolerability because it's a steroid MR blockers, the moiety, the structure is steroidal. You have the second generation one, which is epler or eplerenone. This has much less of a hyperkalemic effect, but it is a steroid MR blocker. So these two medications are used in heart failure. They're used in refractory hypertension as a fourth line drug because you want to block the effect of aldosterone. So these are the two indications for Spiro and epler. Now, finerenone is the third generation MR antagonist, and this is non-steroidal. It is more selective. It targets the MR receptors very selectively, and it has a very high affinity for the MR receptor, even more than what epler has. And therefore, the concern about hyperkalemia, although it is there, if you compare to placebo, still there is a higher chance of hyperkalemia, but it is much less as compared to Spiro and epler. But it does not have too much of an effect, meaningful effect on blood pressure elevation. But through aldosterone receptor blockage, it actually reduces proteinuria very significantly. It also has anti-fibrotic effects. So therefore, use in patients with heart failure and in patients with kidney disease, it seems to be pretty effective. It seems to decrease the need for progression of kidney disease to the need for dialysis and the need for transplantation. It seems to reduce that. It tends to reduce cardiac events, so it is a very interesting molecule. Now the question is that what about the lupus patient? Unfortunately, we don't. The most of the data that we have on this drug currently is in diabetics with diabetic kidney disease, and there it has been shown to be clearly beneficial. The question is it going to be replicated in patients who have non-diabetic kidney disease? Now, the assumption here is that a lupus patient has significant proteinuria. Diabetic patients have significant proteinuria, and so we could actually, because it is useful in diabetic kidney disease, so it should be useful in lupus nephritis and lupus kidney disease. But that is to be shown. So unfortunately, we don't have that data as yet.
Thank you very much for that answer. When it comes to timing of these blood pressure medications, should they be administered at the same time or split into groups of or pairs? And specific drugs I'm referring to are AC inhibitors, diuretics for the morning, calcium channel inhibitors, and CA inhibitors. Could you provide some guidelines in terms of how these should be combined or administered during the course of the day?
That's a pretty interesting question, and I think there's no clear-cut answer to that because in cardiology we tend to use a lot of randomized trials to see whether giving a particular dose in the morning, afternoon, or evening is beneficial in terms of both control of blood pressure, in terms of being able to reduce cardiovascular events, because at the end of the day, you are treating blood pressure because you want to reduce cardiovascular events. At the moment, of course, there is a concept of what is called chronotherapy, and we tend to sort of look at the rhythm of blood pressure or the biorhythm of blood pressure and tend to sort of titrate blood pressure medication or use it accordingly. And people have suggested that you can use ambulatory 24-hour blood pressure monitoring to see in a particular patient to see what time the medication should be given to have maximum effectiveness. But by and large, in daily practice, we don't tend to use it. Most patients will tend to take the medication in the morning or at night time. Now, the most popular time is the morning time, although it has been clearly shown that most medications, especially calcium channel blockers, if given in the morning, has a much better effect in terms of cardiovascular events and overall control blood pressure as compared to giving something in the morning. We must also remember that medications which have a longer acting, long action, or they have a duration of action which is more than 24 hours. By that I mean that the levels in the blood are much higher and the effectiveness lasts more than 24 hours. It doesn't sort of really make too much of a difference whether you tend to use it in the morning or towards the evening. And that is what has been shown if you use an ARB, an ACE inhibitor. For practical considerations also, we tend to look at time and see, for example, if you want to use a diuretic, you're going to have some feeling of going to the loo or the bathroom washroom a little more frequently soon after taking it for some time. You may not want to take it in the daytime, in the afternoon where you're already in office. So therefore, the usual recommendation for a diuretic is to take it as soon as you get up in the morning. One can add a small dose of the diuretic in the afternoon, late afternoon, so that, and usually not at night, because you don't want to be woken up to go to the loo, the washroom, often at night. So diuretics tend to be used early morning. Like I said, calcium channel blockers effectiveness seems to be better if it needs in the night, and that is something that one should consider. When you use an ARB or an ACI and you combine it with a calcium channel blocker, then there seems to be no difference whether you use it in the morning or evening. A beta blocker, preferably in the night, because you can prevent the early morning surge. I mean, the logic of using some of these medications at night is you have this early morning surge of blood sympathetic activity where the blood pressure can go up and the heart rate can go up, and so you're better off. You also have surges of blood pressure and heart rate during what is called REM sleep, which occurs in the early part of the night. And you want to blunt all those surges. So therefore, a beta blocker taken at night is a better choice in terms of preventing cardiac events. So you tend to look at these kind of things. Calcium channel blockers also can cause some peripheral edema, or swelling of the feet. Now that is exacerbated if you're sitting or standing for longer periods of time. So therefore, taking it in the evening when you're actually lying down reduces the hydrostatic pressure on the lower legs, and so therefore the edema may be much less. So some of these things are things that one considers when one starts using medications in terms of time. But like I said, this is more the patient tolerability, whether the patient has side effects or problems with a certain kind of medication being used at a certain time. There's no hard and fast rule. So I don't think there are any strong recommendations either which way.
Understood. So it's quite nuanced and based on the context and the individual circumstances of each patient, as I understand.
I mean, one could use 24-hour ambulatory blood pressure monitoring to see, and watch over a week and see the pattern of blood pressure rise for an individual, and it's possible, you have higher blood pressure in your office, and so 2 p.m. in the afternoon, and so it's better to take it at 12. So that's possible. But at this moment, we don't really do ambulatory blood pressure monitoring that frequency, and therefore it doesn't seem to be practical. I mean, one of the major things with blood pressure is it's common and it has to be practical so that it can be easily implemented. The information can be easily disseminated, and physicians can sort of take a cookie cutter kind of an approach, because that way you are able to reach out to more and more people. So I think because it's a population strategy, more of a population strategy than an individual strategy.
Understood. That's very clear. The next question is, would it be beneficial to combine natrilex, furosemide, and spironolactone in chronic hypertension? And I guess when we're talking about chronic hypertension, we're referring to pressure levels in excess of 160 by 80 millimeters of mercury.
Yeah. If I understand this question, I mean, it could mean two things. Whoever has asked this question, one is that should I combine a diuretic with something else if the person's blood pressure is more than 160/80? So one part of the question could be, should I be using a diuretic along with another class of agent if the blood pressure is high? Obviously, that is what the societies today, most of the societies, American, the European, the International Society, the Japanese Society, all these societies are recommending what is called a single pill combination approach to initiate, in fact, blood pressure. And certainly at levels of 160/80, which actually is stage 2 hypertension in the US guidelines, you would use a dual medication, single pill combination approach. So certainly one part, if the question was that should I be combining /natrilex, furosemide, or spironolactone with something else to control high blood pressure? Yes, I mean, natrilex would be wise. Furosemide, by and large, is a loop diuretic. It is not used as a standard antihypertensive. The only place where you would use, furosemide is if the patient had kidney dysfunction and the GFR was less than 30 mils. There, if the GFR is less than 45 mils, the thiazide type diuretics do not act; they're not effective. Chlorothalidone and napamide have some use up till 30, but less than 30 mils, they are not effective at all. So furosemide is not really a standard medication for blood pressure control unless there is kidney disease or significant kidney dysfunction. And the third is spironolactone. The spironolactone can be used individually and in combination with others, except for the fear of hyperkalemia, especially if there is suspicion that some of the blood pressure is because of higher aldosterone levels in the body. And in fact, we know that mild hypertension, a significant number of people will have a slightly increased aldosterone levels, and therefore we find that spironolactone is useful in resistant hypertension, for example. So you can combine it with a non-potassium retaining kind of antihypertensive, which is rare because most commonly used antihypertensive today is an ACE inhibitor or an ARB. And combining an ARB and ACE inhibitor with a spiro is tricky because of the risk of the fear of hyperkalemia. The other part is that, can I combine natrilex, which is a thiazide diuretic, furosemide, which is a loop diuretic, and a spironolactone, which is a potassium-sparing diuretic, all the three together in trying to treat blood pressure? How about combining three diuretics? Well, like I said, combination of natrilex, which is thiazide type diuretic, or a thiazide, for example, hydrochlorothiazide, in combination with another potassium-sparing diuretic like amiloride or triamterene. They are similar to spiro. They are not the same, but they are potassium-retaining diuretics. These have been quite popular, in fact, and increasingly we don't find them in the market anymore. But let's say 5 years ago, because most of the societies now tend to use HCTZ. Most of the pharmaceutical companies have switched over to HCTZ, and nowadays combination with chlorothalidone. So you don't find this combination. Pharmaceutical companies are not making this, but it has been clearly shown earlier that combining HCTZ or a thiazide type diuretic along with a potassium sparing diuretic is far better than using HCTZ or thiazide alone in terms of hypokalemia, in terms of ventricular ectopics, in terms of sudden cardiac death. So obviously it makes sense in combining a thiazide-like diuretic like chlorothalidone, natrilex, along with a potassium-sparing diuretic like spiro or amif or amiloride and triamterene, in sort of using a combination of a diuretic to treat blood pressure. It's a good idea. In my practice in India, a drug was available which is called ditide, a combination of a hydrochlorothiazide and triamterene, and also in a combination with amiloride. We had these combinations. We don't have these combinations anymore because somehow the pharmaceutical companies have stopped using this and making this, and they've gone on to combination of ACE inhibitors, ARBs, and diuretics, which is hydrochlorothiazide. Furosemide, like I said, is not recommended for hypertension, but I do think that if the patient has a lot of volume overload and you want to get rid of more volume, then you might want to combine with furosemide. The only place where you combine furosemide and a thiazide diuretic is when you want to get rid of a lot of water, and sometimes to reduce resistance, diuretic resistance. So for example, combining these two medications sometimes prevents what is called tubular hypertrophy. So the furosemide can become more sensitive. But that's an unusual situation, and by and large, you would not use furosemide for blood pressure control.
Thank you very much. It's a very comprehensive answer. That brings us to the last question in this podcast. And I guess it's very relevant to the times we find ourselves in. One of our members asked whether you had any specific advice for diuretic use, in a population with high exposure to COVID-19. And are there any specific considerations that should be taken into account when treating those who've already contracted and recovered from this infection? Are there any specific risk factors for these particular patient populations that should be factored in when using diuretics for hypertension treatment?
Of course, with COVID-19 being a pandemic and so many people being affected, a lot of these patients have been on blood pressure medications. And initially, there was a controversy whether we could continue to use an ARB ACE inhibitor because the COVID virus uses these receptors to sort of take entry into the endothelial cells. And obviously, up till now, it's almost 2 years now, we have not found any evidence that continued use of an ACE inhibitor or ARB is, detrimental to the patient. In fact, stopping or changing this medication is more detrimental than sort of continuing the same medication. To some extent, some data suggests that it is, obviously these are cardioprotective medications, and if you take them off, then you are exposing the patient to cardiovascular risk, and COVID itself does carry some risk of cardiovascular illness. And you don't want to subject the patient to a second illness or second risk by removing these medications in a well-controlled blood pressure patient. As far as diuretics are concerned, again, people have tried to look at it. There seems to be absolutely no reason for us to use it differently if a patient who suffered COVID or recovered from COVID, or the risk of contracting COVID while on a type of diuretic. But yes, patients who get to the hospital, who get hospitalized into critical care, who may require ventilation, BiPAP, or whatever, there you could have a certain amount of fluid balance issues. Some of it is ARDS linked, some of it is because of multi-system involvement, where you can find that patients either are volume extra or volume depleted. In those kind of patients, the same concerns that apply for diuretic use in any kind of an illness apply. So to my mind, there is no data which suggests that we should be using diuretics differently in these patients. So I would tend to continue using it the way I've been using it in all my patients otherwise.
Understood. And that also, I guess, implies that for the usual treatment regimen of COVID-19 patients, there is no conflict. In other words, there are no drug interactions that are potentially risky when it comes to combining diuretics with the typical therapeutics used for treatment of COVID-19?
Yeah, so most of these patients who are, most patients who are critically ill, I mean, they do have fluctuations in blood pressure, and you can, so you're trying to sort of, these are, they cause changes in volume, they cause changes in electrolyte levels. So obviously, any patient who's hospitalized, you are a little careful with these medications, which can perturb hemodynamics. So you would use them, most critically ill patients again would tend to have a lower blood pressure because of the illness itself. So a lot of times you may want to stop the diuretic completely. You may want to use a loop diuretic SOS in case you want to get rid of fluid or more volume. So those things are there. So it is not that once the patient is ill and hospitalized in the critical care, you relook at the medication the patient is taking. And sometimes you may want to withdraw some things temporarily. But we don't find that there's any, if there is a need for a use of a diuretic in a patient who has COVID or recovered from COVID, I don't see how it changes the management as compared to anybody else who is critically ill with any other illness. So what I'm trying to point out is that COVID itself does not cause a problem. We have no medications per se for COVID, which are specific to COVID. Now, whether we come up with a medication, recently there have been some medications, those medications do not have any interaction with the diuretic. So once we start oral treatment or intravenous treatment with the medication for COVID, then we have to see whether that interacts with any diuretic. So far, no.
Well understood. Thank you very much. That brings us to the end of our podcast.
Thank you very much for having me.
We hope to bring you back in the future for another talk on a cardiology topic. Thank you very much.
I would love to.
Thank you. Bye-bye.
Thank you, and bye-bye.